So great. Let's start. I'm going to talk about carbon fiber and how do I implement it in my practice. And we're going to talk about some of the limitations that we might have or don't have and see how we can overcome them, if at all. So let's see if it's okay. These are my disclosures. Yes, you can see it. Perfect. So what are the limits that we might have? Do we have a great option for anterior reconstruction? Do we have any limit with the length of construct that we can do with carbon fiber instrumentation? Can we navigate these instruments or screws? Does the Tesla matters when we check our construct? And how do we manage infection with carbon fiber? Is it different than titanium? Is it different than degen trauma in compared to cancer? So yes, let's take a look at things. So just kind of background and recap of what we did so far. With today's technologies, we can take apart the spine and put it back together, like this 2-cage corpectomy for tumor. And then we perform the post-op MRI, and that's what we see on the left hand side on the bottom. A lot of artifact, we can't see anything. And how do we, is there any better option? So just a brief recap, generally on metastatic disease, and more mainly for the students, for the residents. In the metastatic disease, the goals are largely palliative. They have a systemic disease which has to be controlled with systemic therapy, and we are talking about a focal problem in their spine. We want to improve or at least maintain neurologic function through spinal cord decompression, either with surgery, radiotherapy, systemic therapy. We need to stabilize an unstable spine and provide pain control, which will improve the quality of life. And how do we evaluate these patients? And we have the NOMS paradigm. That's what I use. These are the 4 things that we think about every time we see a patient with spinal metastasis. I will not talk about it because that's not the topic of the discussion, but just generally. And then we need to establish the diagnosis. We need to know what is it? Is it a MET? Is it a primary tumor? Is it an infection? Is it pseudoprogression? We need to get a biopsy, very important. And then we want to know, is it a bloody tumor or not? Because there's a big difference in treating RCC versus a breast met, right? This is a pre-embolization angio and post-embolization angio for an RCC, completely different, correct? This is a surgical treatment. We need to decide what we need to consider when we talk about surgery. What is the purpose? Are we curing the patient? Is it palliation? Will the resection be en bloc or intralesional? Does the patient need stabilization or not? How will the wound heal with steroids, radiation, nutritional status? We talked about it before. And of course, the general medical status of the patient. This is just putting together all the surgical options into a diagram. It will look something like that. And you can screenshot that, the residents or the medical students if you want to take a look later. Usually what we do is just separation surgery. On the left, you can see the spinal cord being squashed by the tumor. And on the right, you can see CSF around the spinal cord. And that's usually enough to liberate the dura and the spinal cord. But then the artifact and imaging is a well-known problem for when we want to follow for tumor recurrence. And is there anything we can do differently? And this, of course, looks better. And I'm personally using carbon fiber on 99.9% of my tumor surgeries. And I'm very happy with that. But in addition to improved monitoring due to better visualization, as we could see for disease progression or recurrence, with dose delivery and accuracy would be improved with carbon fiber instrumentation. So this question led me and my team, my research into this study. We wanted to investigate the dosimetric accuracy of carbon fiber versus titanium instrumentation in the thoracic spine, which is the most common place in the spine for metastatic disease. We wanted to simulate as accurately as possible the dosimetric calculations and the real-life scenarios. So we used a non-fixed human cadaver. And we took a thoracic spine, we exposed it, and two segments were instrumented with rods and screws, carbon fiber on the right of the screen and titanium on the left. Dosimetric chips were installed in the epidural space. And here I'm retracting the thecal sac. You can see the carbon fiber screws at the top, the dosimetric chip ventral to the spinal cord or the thecal sac. And then we filled up the space with gel, so no air will be there. And these are fluoroscopic pictures from the surgery. Titanium at the bottom, carbon fiber at the top. You can see the dosimetric chips with the round BBs, round dots. And these are the dose volume histograms that we can see on the right. Yellow is the spinal cord, and it shows it doesn't receive most of the dose. The thick pink lines are the readings from the same level chips, and the thin lines are from the adjacent chips. We can see that not all the same level chips receive the same dose. It depends on the proximity of them to the high isodose area. And the histogram and plan is for the chips placed near the carbon fiber screws. And these are the rest of the histogram. This is for the chips placed next to the carbon fiber screws, but above the rod, and more histograms, more. We'll skip those. We'll cut to the chase. This table represents the mean dose each chip received versus the calculated dose it should have received according to the planning software. And let's focus on the near the group screws. And to the screws near on the chips near the screws. Chips placed near the carbon fiber instrumentation, where normally the radiation scatter should be high, we can see our accuracy is very good. The percent difference between the measured and calculated dose is very small compared to the near the screws in titanium. And if we average the numbers out, we get this table. The p-value is significant for the near the screws group and the sum group. It means that if you have a titanium screw, the area around it has a much higher uncertainty and unreliability, and near the screw means about 1 centimeter. And then after we completed that part, we wanted to see what will happen if there will be more titanium in the field and more artifacts. So we took 2 cadavers, and we instrumented the cervical spine. We did a 2-level corpectomy and instrumented in both cadavers, inserted the dosimeter chips. You can see on the left carbon fiber cage and plate, and on the right carbon titanium cage and plate. The dosimetric chips are seen as the small dots there. And again, we have the histograms. And let's get to the numbers. You can see the measured versus the calculated dosimetry. Extrapolating from this data, there were 3 groups of dosimeters that had a significant difference in mean variability of calculated compared to measured dose between carbon fiber and titanium. Ventral to the spinal cord had a 68% difference in mean variability of calculated compared to measured dose between carbon fiber and titanium. Lateral to the spinal cord had a 30% difference between carbon fiber and titanium. So less variation in calculated and measured dosing of radiotherapy in post-corpectomy patients with carbon fiber instrumentation may lead to improved radiotherapy delivery, less overdosing or underdosing of a tumor or an eloquent area, and better complication avoidance. Now let's see a case real quick. We'll skip a lot of parts because we don't have a lot of time. This is the patient. The 14 was the SINS score. So we went ahead to do surgery. The ESCC score was 3. Wilski score was 3. And I have a couple of videos with one of my math students that narrated it. That's more for the math students to see, and the residents, how we put in carbon fiber screws. This is the general exposure. We can see the navigation array to the right of the patient. We are drilling the pilot holes, cannulating the pedicles, This is the carbon fiber screw going in. I don't know if you can hear him talking, but maybe not. We probably can't hear him.
We can smell the bovie smoke.
Can you see the Excel?
Yes.
Okay, so this is performing the laminectomy. I will skip it. This is finding the nerve root, the exiting root. This is ligation of the nerve root proximal to the VRG. I don't know why you can't hear the audio, but that's fine.
You're doing a good job.
And this is ligating the nerve root and going in with curettes and with a drill to perform the corpectomy. Transpedicular corpectomy can go very far. Resecting the PLL is very important to have a good separation. And then I sometimes, most of the times, use cement to reconstruct the anterior column, very cheap, very quick, and you don't have to have a big approach to inject it. So I'm preparing the syringe and I'm preparing the cement, and you can see I manually mix the cement to avoid any air bubbles to be in the cement, so they won't expand and push on the spinal cord because it's an exothermic reaction. I fill up the cavity with the cement and push down with pen filled free. So, and irrigate continuously while I'm doing that, because it's an exothermic reaction. We don't want it to burn the spinal cord. We are constantly pushing down the cement, not to overflow. If there is some overflow, we take it out. And then once that's done, who knows why I have to compress? So I ask a lot of residents and med students, they don't know why we need to compress against the cement. The cement is not an expandable cage. It is wobbly when it's inside the anterior column, so we need to compress against it. So this is the different compressor that you compare to what you saw before in the demonstration. That's what I use, and again, it's from the same company. I compress against the screw and then lock it, and then by that, I'm locking the cement down. And we can see that here, how we need to measure the crosslink. This is the crosslink, which is a fixed distance, so we can't compress the crosslink, so we have to put it on the rod before, ahead of time. This is the compression and locking down the screws, and this is the final construct. This is how the cement looks. You can see, you cannot see in the x-rays the screws. This is the MRI, that's the CT. And then I get another MRI, and who knows, who can tell me what's the problem? Why carbon fibers look so bad on this MRI?
Yeah, the scanning type or resonance, material resonance.
So this is carbon fiber. What do you mean scanning type? What would you do differently?
Play with your rebound time, so T1, T2, things like that.
So yeah, very simple. It actually was mistakenly my mistake. I did it with a free Tesla MRI, and they recommend using a 1.5. So this is a free Tesla, very nice picture. Look at that, same search, same patient, 1.5. I go back, free Tesla, 1.5. Beautiful, like completely different. But then unfortunately, my first infection happened, and the guy got infected. And actually wasn't infected, he had a seroma. He had a post-operative seroma, and I asked IR to put in a drain. Who knows what's the problem with this drain that IR put placed?
There's a metal lead filament in the catheter, a radiodense material.
So he had an infection after placement of this IR JP drain. So the problem is they put it so close to the wound, right? It's right on the incision. So it unfortunately led to an infection, my first infection, and I had to open him up. From the infection, the set screws got loose. And again, the first time it happened to me, but I actually didn't know what to do. I actually treated it as any other infection. I removed the screws, replaced the rods, replaced the set screws, replaced the screws in themselves, and then because there was some lucencies around the screws, I extended the construct up and down a couple of levels, and this is the final construct. And I heard from the companies that this is I think the longest construct in the country for carbon fiber. And this is how it looks. Again, no problems in reducing the rod to the screws. It fitted, perfectly. Maybe I had to play with the height a little bit of the screws, but eventually went in nicely. So do we have any limitations? Anterior construction options? Yes, there are options to put in a carbon fiber cage. It's still, I don't think it's still great. So if I can, I use cement. After this presentation was made, I actually used one of the carbon fiber blocks for the anterior reconstruction, and it worked actually fine. Length of construct, I don't think there's any issue after looking at this, so you can go as long as you want. Can you navigate this? Yes, I do it all the time. I don't rely on fluoroscopy because I want to have a perfect construct and not to. I don't want to come back again to revise the screws. Tesla matters, yes, definitely. 1.5 only. 3 Tesla will throw you off. You will think that you put in titanium. So no, 1.5 only. Infection, it happens, unfortunately. Revision is very easy as with titanium. Wash it out. You have plastic surgery help you out with closure, wound vac, bank powder, and that's about it. These are my conclusion. There's no perfect algorithm, but tumor board is very important. We need to protect neurologic function. And our patients are not just, an imaging test. They are not robots with preset predictable response to therapy. They are human beings, all have stories and wishes that complicate things so much that all classification and tumor boards, while their input is so necessary, is at the end limited. Thank you so much. It was a great pleasure.
Thank you, Miki. We have Dr. Galgano in the wings, but let's ask you 2 quick questions from mine at least. First of all, great presentation, nice stuff, great video, and appreciate the honesty also how to handle complications. So first question is, you mentioned PMMA. Is that as good as your carbon fiber stuff in terms of allowing radiation to go through without deflection, scatter, etc.?
Yes, no issues at all. The radiation oncologists, they love it. They have no issues with that.
Great.
Not at all. We haven't done a CT mammogram since I'm here. No CT mammograms, and yeah, works well.
I saw Dr. Bilski nodding his head. Dr. Bilski, agree?
Oh yeah, Ori actually, Barzilai looked at that, and there's no change in outcomes or dosimetry with cement. It's pretty inert for photons for sure.
Super. And then the second thing is, I saw Warren Buffett, Buffett kind of as a sponsor of your center. The cost factor of carbon fiber is substantial. You're speaking to one of the main cost cutters in our healthcare system. And in my time, we have more than halved the list price of screws. And this is still just something where our administrators battle. And I'd like to have these there. I think the concept sounds great. How can you convince your administrators to do this without having a certain W. Buffett in the back of your resource allocation?
Great question. When I came here, there was no spine cancer unit, so that was kind of a deal breaker for me. I said honestly, I want to come, but I want to use these screws because that's the future, and we don't want to stay in the present or in the past. So if we want to be out there, we need to use them, whatever the cost is. That was one thing, and then on the other hand, we negotiated. Everything is negotiable, and I can't disclose prices, but it's not a problem. If you really want to use it, the companies will help you to get there and to put these screws into the patients. It might be a little bit more expensive, but it's worth it. It's completely worth it. And eventually it's negotiation, and they will help you to get to put it in the patients.
Dr. Katzir, I want to make you my chief negotiations officer in Seattle. Not a good negotiator. Bilski, you had a comment?
Thanks so much. Just a quick, make a great, really great presentation. Super. Quick question. The dosimetric studies you showed, those were the photons or protons on photons?
Yes.
So that's interesting. You know, with volumetric arc therapy, we feel like we can overcome the shielding with titanium, but that's a super study that is, I think, critically important. Two quick comments. One is the images that you showed with the artifact on the 1.5 Tesla magnet at the beginning. I think, you know, the biggest problem we've always had is those big titanium expandables with that big ring that puts that artifact across the deconstruction. I think with titanium hardware and subtraction artifact MR imaging, you probably can overcome that pretty well. But I mean, peak is obviously significantly better, but a lot of those things we can sort of overcome. The other thing I would suggest, and this may have been a different case because you had, you know, your screws sort of, the caps came undone and maybe you had some lucency, but most of the soft tissue infections most of the infections post-op are soft tissue and not sort of bone screw related. So you might think about just washouts with rotation flaps to bring vascularized tissue in. And a lot of people have had pretty good success, not changing the hardware out, but just a big washout and flap over, and then 6 weeks of antibiotics and then oral suppressives, just as another strategy to overcome that if that's meaningful.
Good, excellent comment. And regarding the plastics closure, the flaps, it's funny. My only infection was when I closed the wound. That was the patient that I closed. And not plastics. So that's a lesson learned.
Thanks, Miki. Brilliant. Thanks.
Thanks for the comments, Mark. And thank you again, Miki. And we'll move straight to Chapel Hill, North Carolina. He's been amazing.